Welcome to Let's Talk Micro. Hello, everyone. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. Let's Talk Micro, it's available on Spotify, Apple Podcasts, Google Podcasts, Stitcher, TuneIn Radio, Pandora, GoodPods. Wherever you listen to your podcast, you can find Let's Talk Micro. I am also on Instagram as Let's Talk Micro, no apostrophe, and on Twitter as Let's Talk Micro 1. I am also on LinkedIn as Luis Plaza, so go ahead and follow. I always like to post pictures of organisms, and I give updates as to when the next episode is coming out. So go ahead and follow, leave any suggestions, comments, any podcast topics, any feedback. It is always welcome and appreciated. And if you haven't checked the previous episode of Let's Talk Micro, go ahead and do so. It was a great interview with Claire Danielson and Sarah Lou Allen from Michigan Tech University from their Medical Laboratory Sciences program. So they came on board, they talked about their MLS program, and they talked about the Summer Youth program. So we are always trying to bring awareness to the medical laboratory sciences profession, and initiatives like these are ones that they really help the profession because these programs, they involve high school students. So by the time they go to college, they already know that medical laboratory sciences is an option. So it was a great interview. I had a great time. And this initiative, this summer youth program with the MLS, it's been going since 1974. So that's amazing for Michigan Tech University. So when you get a chance, go ahead and check it out. And today's episode is another interview episode. So I had two guests on this episode, which are Jeniffer Dien Bard. She's a Director of Microbiology at Children's Hospital in Los Angeles. And I also had Dr. Amy Leber from the Department of Pathology Laboratory Medicine from Nationwide's Children's Hospital in Columbus, Ohio. So they came to the podcast to talk about an article that was titled The Hidden Crisis in the Times of COVID-19. And in this article, they talk about the shortages that we are facing in the laboratory. They talk about, the wages and how, for statistical purposes, they're currently the medical laboratory technicians and the medical laboratory technologists or scientists, they are grouped together. And they talked about the challenges that we have in the laboratory. So as far as hiring people, staff, the time it takes to train them. They said something great, and it said training microbiologists does not happen overnight. And that is something that it is very true. And everyone in laboratory medicine needs to understand that micro sometimes, it's a little bit different from other areas of the lab. So there's a lot of technical terms, there's a lot of information, and the flow, it's different. So everyone needs to be aware of that. So they talk about solutions, they talk about how, the medical technology programs or medical lab sciences programs, they have decreased over the years. So many challenges, and they also talk about solutions. So it was a great interview. I really like, how they present the problems, and, they're there, and it's time to talk about solutions. So great interview. So let's go ahead and check it out. So on today's episode, we have two guests to discuss an article titled The Hidden Crisis in the Times of COVID-19, Critical Shortages of Medical Laboratory Professionals in Clinical Microbiology. This was published in the Journal of Clinical Microbiology for the American Society for Microbiology on June 6th of this year. So with me here in Let's Talk Micro, I have Doctors Jeniffer Dien Bard and Dr. Amy Leber. Doctors, welcome to Let's Talk Micro.
Thank you.
Thank you for having us.
My pleasure. So let's go ahead and start with an introduction.
Sure. I'm Amy Leber. I'm a Director of Microbiology and Immunology at Nationwide Children's Hospital. So we are a pediatric hospital that serves a wide range of patients in Central Ohio. And we have a wide range of testing we offer. And including molecular and things like MALDI-TOF. And then Jeniffer.
Hi, Jennifer Dien Bard. I am the Director of the Microbiology and Virology Lab at Children's Hospital in Los Angeles. So similar to what Amy mentioned, our patient population ranges from acute care to highly immunocompromised individuals. We're a quaternary care freestanding pediatric hospital, and we do have a range of testing as well, from basic micro, MALDI-TOF, and then molecular.
Okay. So this article was actually a review. So what was the purpose of this review?
Well, this all started prior to the pandemic. As a clinical microbiologist and as a laboratorian, we're constantly looking for people to hire. At my own laboratory, we are never fully staffed. And it is a recognized crisis that's been ongoing for well over a decade. It's very hard to move the needle on this. And particularly when there's also shortages in other professions like nursing and allied health. So really, we wanted to do a review of the situation specific to microbiology. So as a subcommittee within ASM, Professional Standards and Workforce Issues, we started out to do just a survey of microbiology labs to discuss what are their challenges and issues with staffing. That's really where it started.
As I was reading the article, I saw that it talked about the licensure for personnel performing testing under the CLIA standards. Can you talk more about this?
Sure, I can comment on that. So the requirements are different from state to state. Every state has their own specific preferences, it seems. There are currently only about, I believe, 11 states or so that require licensure, which includes California, New York, and Florida. The remainder of the states do not require specific licensure to work in a CLIA certified lab. However, certification through the American Society for Clinical Pathology, ASCP, even though it's not required, most employers do prefer to hire certified lab scientists with the specific certification sought out through ASCP.
Okay. And I see on the article that there's also data for the number of individuals employed as MLS and MLT. It is combined on the Bureau of Labor Statistics. So it is mentioned that doing this, it is inaccurate. I was actually, before I was an MLS, I was an MLT. So definitely I know that the differences, but for the audience, can you elaborate on why this is inaccurate?
Sure. So, a med lab scientist versus a med lab technician, they are basically two very separate professions that consists of very different training and certification requirements. For an MLS, which is the med lab scientists that are pretty much working in the microbiology lab, but also other labs, this involves, I should say, a broad range of clinical lab testing, including highly complex testing. And the profession and their job description is very different than what an MLT would do, which is more so from the front end specimen processing side, but also some moderate complexity testing. So to combine the two is really just doing a disservice for both, because it's two very different and very important professions with two different certifications, but also salary ranges. And so the fact that we're not really, I guess, being accurate about what the average salary or median salary is in the US for both of these, it just speaks to us not really understanding what the profession is, but also it does a disservice from the salary standpoint when you're looking at if there are prospect students that are looking for professions, to really understand what they could potentially get, as compensation from the monetary standpoint.
Yes, and as you mentioned it, I do definitely see, and with the monetary standpoint, and there are some places where actually the MLTs, they pretty much perform, they have them doing the same functions as an MLS, and then you have this huge disparity in pay. So you get an MLT that's been doing this for 20 to 25 years, and they're maxed out at X amount, and then someone that comes in, graduate as an MLS, starts making pretty much the same or very close, and they don't have the experience. They haven't been there as long. So definitely, yeah, there's definitely many differences between MLT and MLS, job description, pay, and more.
And it can be a very big dissatisfier to the employee to know they've worked. I mean, it can go both ways. With an MLT, you only have to have an associate's degree. So they didn't put in the school years that their counterpart is a medical laboratory scientist. So it is a difficult balance in the workplace, but sometimes we just need literally bodies to fill a position. And we're to the point where, we're having to think creatively how to fill those vacancies.
Yes, definitely. And, to add to that, sometimes, we even have like the AAB, which is big in Florida. So if someone has a bachelor's or they do the MLT, then they take that test and they get licensed as an MLS. So some differences there. So can you briefly touch on the vacancy rates in the laboratory?
Yeah, our survey didn't really look at true vacancy rates. ASCP does that every 2 years, I think, and it can vary by different parts of the laboratory. But in microbiology, what we found is nearly 80% of the labs responding to our survey had at least one vacancy. And we see that either through ASCP or our data, it's very hard to fill places in rural places, second and third shift. It's often very problematic. So what happens is we have to limit our service either by cutting testing off at, after 8 p.m. or things like that. So vacancy rates are problematic, but if we're trying to be creative to fill them, I don't know if you feel that in your own hospital, but our vacancy rates have made us think of shifting work. We used to offer things 24/7, which now we're not. I'm sure Jen has the same thing going on. It can be very, very problematic and really is affecting patient care. So,
yes.
Yes, and I think that was. Oh, sorry.
Go ahead, please.
Add to that. I was just going to say that, yeah, and I think that was one of the main reasons we wanted to put together this review, and also to highlight that the lab medicine is a very important part of healthcare, and to encounter these issues with regards to staffing in this specialty is going to directly impact all areas of medicine, not just laboratory.
Yes, and so as Dr. Leber, so definitely I did I have experience in my facility this shortages. We used to, prior to the pandemic, we were getting staffed enough where we even had let's say we had even urine cultures being read on all 3 shifts, and I took part in this. We were even reading wound cultures on night shift, and just to keep things going because it's such a large facility. And then we went through, so many shortages that it was hard to find people. So we have to close some of those benches at night, keep it maybe on a stat basis. Then that will be more for a molecular test or a rapid test. But then we had to resort to, we hire probably about 6 to 8 techs from the Philippines through the program, where they applied. And then they come in and, having said that, and I was talking about this before we started recording, it turned out to be a blessing, actually, because it was, I never worked with techs, from other parts, but definitely, such great work ethic, such teamwork. So it made our team so much stronger right now. So definitely, this is something that we should continue looking at in the future.
Yeah, I think in California and other parts of the country, that's not a totally foreign concept. Somehow in the Midwest, if you're not at a huge institution, that alone would be a big undertaking. But you're absolutely correct that there are some excellently trained individuals outside of the United States that, if we're creative and get the help from our administration, we can, bring into our lab. That's a great idea.
It definitely is, and this will be a whole separate topic, but a little pet peeve of mine. I was talking about work ethics. Nowadays with technology and cell phones, we see that people tend to be more hooked on with them, and you see a lot of these, phones in the hallways, and so all this text, they don't bring that to the table. It's just work, 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 work. On their breaks they do phone calls, social media, whatever. But it's kind of nice to see that in this day and age. So as far as there's definitely a demand for medical lab scientists and MLT. So, but then the programs, right, the training programs, they have declined so much. Any ideas as to why has this happened?
I'll take this one. Back in the 80s, there were like 800 or more college-based curricula for medical laboratory scientists. I mean, you went to college and then you graduated with that degree. That's dropped down to about 200 now. The reason why, I'm not exactly sure. Usually it always relates to money. These are expensive programs to maintain, and maybe the demand wasn't as great as it is now. So unfortunately, it's dropped to a level where just through the college-based programs, we can't produce enough people to meet the needs. So there are other avenues which are reviewed in the article where you could get a bachelor's degree in science and then have 1 year of training in a laboratory, and then you could get accredited. But not a lot of people know about those programs through ASCP. Sorry. That's another thing we want to promote, that there are ways to get the training component, the in-laboratory training you need, even if you have a bachelor's degree that's not in medical laboratory science. So it's important to know that. And some of the best people we've trained on site and really have been fabulous employees. But it's a big commitment from the employer, because basically you have to pay them while you're training them. So it's a challenge, but I think it's well worth it for many laboratories.
Okay, yeah, definitely is. And even those programs that we do have, they even have sometimes enough supplies and personnel to maybe graduate one class at a year. So you have at one point in time, you have maybe 60 students and 30 are your seniors, which are just going through their practicals. And then you have what they call your juniors, which is they're just starting through the program. So even with the low amount of number of programs that we have, not as many techs are produced. Okay, so now let's switch to shortages for clinical microbiologists. Can you talk about those and the issues filling those positions?
Sure, I can tackle this. So this is in line with what Amy was just talking about. We have less training programs. So, and the training programs are for mostly the generalists. So you have 4 other options that they could, or I guess 4 other specialties that they could explore. So that in itself results in shortages in clinical microbiologists. This is something that has been going on for years. I remember when I was a fellow over 10 years ago, my director at the time was presenting on shortages in MLSs and what we should be preparing for. And here we are kind of talking about the same thing, but I feel like it's been a lot worse because it's a pandemic for various reasons. People are retiring earlier. People are burnt out and switching professions entirely. At the same time, there's just not a lot of advertisement and knowledge of these training programs or limited training programs. So we've had a lot of issues in filling positions, lots of competition, but not enough people in general to try to compete against other places. And so similar to what Amy said, we started to kind of increase our own internal training so that they can pursue their license, I guess, certification through ASCP and then licensure through the California state. But it's a long term, it's not a quick solution because it takes a year to train them. And you're also training while you're short staffed, which, is another fun part of it. But that's one of the things that we're trying to do right now to try to help, at least in the future, alleviate some of these issues.
Okay, yes, and you mentioned it definitely with the pandemic. We saw some of the more senior techs, they had been working for 20, 30 years, and maybe some of them, they might have some health conditions or some may not, but they were like, you know what, this COVID, maybe this is the time for me I don't want to get exposed to this, get into this. So, and I also saw that sometimes, maybe some packages were offered and some of these more senior techs, they took them and so they retire. So that definitely contributed to the shortage of them as well. And from those things that you mentioned, I'm also going to talk about them, but I'll talk about after I ask this next question, which is, when I was reading the article, and I love this line because, it is so true. And I always had issues trying to make people see this, not everyone, but some. And it is, training microbiologists does not happen overnight. Can you please talk more about this?
Sure. As you know, microbiology is much more manual than instrument-based, even still, so that it requires a level of comfort with IDing things morphologically, having the skills to identify organisms by biochemical tests, the like. So, for example, in areas like mycology and acid-fast bacteria, those cultures take so long to grow, and we're still using a lot of morphologic characteristics to ID fungi. So it can take years to really become proficient at this. So by the time we train someone, give them 2 years of experience in an area, and then what happens is we'll lose them. So we don't have any depth of experience in these areas that really take a long, long time to learn. Things like IDing parasites from smears, or doing gram stain reading is a big one. We still have incredible difficulty training people for second and third shifts to read gram stains with any consistency. And it's just because they haven't been around long enough. That's just something you learn through experience. So unfortunately, we end up with corrected reports. And it's not something we want, but we're left with, we have to have someone here to read it. And if they only have 2 or 3 years of experience and there's no one on the ship that they can run something by, that's when we have errors and things. So that's why it's so important to have your leadership, the C-suite, so to speak, recognize that I'm not putting down chemists, but chemistry is a different profession in terms of the depth of experience you need as opposed to something like micro. So we're still seeing that. Even if we have all these advances, we still have to have some level of expertise that can't be given to someone with 6 weeks of training.
And I'm just going to add to that really quickly, just to chime in. It's 100%, especially in the more specialized area like parasitology and mycology, but even in basic bacteriology, gram stain is a very underappreciated art, in my opinion. I think that just the sheer reading of a gram stain can inform a provider quite a bit about for us about the specimen type itself, whether it's a good collection or not, but also how significant of a sample it is and what potentially could be growing and causing the infection. And I think we are slowly losing that art, in the sense that we just don't have enough trained staff to really know how to knowledgeably read the slide, but also appreciate it. And I think there's a fear almost of reading gram stains because, if you're not comfortable with it, you want to avoid it, and you want to avoid those corrective reports, basically. But I think it just kind of speaks to that. It's something that doesn't happen overnight. It takes years of experience to really become proficient. And we really need to tackle this now, or else we're really going to lose that art.
I definitely agree with that. And, the gram stain, like you said, it's such an important tool. And sometimes, it needs it's, we train people and it needs repetition. It's so important, both, direct when you get your sample and, indirect with your cultures. It will say, it saves time. And I was talking about this before we started recording, and I said this throughout my episodes with the multitop. Sometimes, you run something through the multitop many times when you can have your answer. All right. Just doing a quick, or it can at least point you in the right direction, right? If you need to rule out something real quick, you do a quick wet prep or a quick gram stain. Oh, I have GPR. It's not like I'm looking for, or it's yeast. So let me go this route. And it is something that it takes a lot of time, and that's why I think, with the students, when I teach in the lab, I have them the whole year. They're doing, as part of their exercises, they're always doing gram stains. So they have their sheets, and on the organisms, they're gram staining. And at the end, I collect those sheets and I give them points, for their work. So they're rewarded, but at the same time, they're learning, because it's something that you can, up to even we might have many years of experience, but we can still over decolorize, we can still under decolorize. And that's without talking about these automated systems, which I think, in my opinion, the techs should be really comfortable doing the manual staining before they can actually jump to the automated staining. A reagent runs out, something is off. Huge difference between saying gram-negative cocci and gram-positive cocci.
And you wonder why, like on our benches, we have readouts of normal cutaneous flora. And now the newer techs have MALDI'd every single thing on that plate to determine its normal cutaneous flora. When in the past, you do a gram stain and a few spot tests and get to that exact answer. So I totally agree with you.
Yes, that's the yeah, it's challenging. Like, you go in, you're following someone, and then in that culture, you have 6 or 7 workups about things that were spotted, and they were either the same or different. And this ties up to the whole that, this doesn't happen overnight. You only get proficient with these organisms, and this cultures by seeing them over and over again, by doing the biochemicals, that's why before, when we had Vitec and other systems, you kind of knew what you had before you even put it on the instrument. So you're just doing the instrument to prove it, to confirm what you have, but you already know. And this takes time. And this is something that everyone needs to understand, because, like I said, chemistry, hematology, valuable parts of the lab. You need those results. They're very important, but they don't work the same. You can resolve your hematology issues, within the same shift. Maybe a few hours, you have a clotted sample, request a new one. Chemistry, you have a questionable value, you do a dilution, recollect. With micro, sometimes, it can take 3 to 4 days to produce a final result. So it takes time, and someone has to sit with that person to train them. So you have 2 people there, like I said, so they have to sit there the whole day. And so it's a time-consuming process. Okay, so let's go ahead and talk about solutions.
Well, fortunately, there's a lot of people working on this, but unfortunately, it's been the same for about 10 or 15 years. So there's no easy or fast fix to this. But obviously, if we had more 4-year programs in medical laboratory sites, that would help. I think colleges are a little hesitant to bring those programs up. Again, to your question, why did it decline? I'm sure it's a financial hit, or an investment to have a big training program, but we do need them. Also, each person that comes out of those training programs needs a practicum site, just like you did. You went and trained in a hospital. So that's an investment, either to be an accredited training site or even to be a non-accredited site. It takes investment from the techs that you already have, and it can slow things down. But in the long run, it's a win for the site. Some other things that we like to think of innovative ways to train people. There's a lot of online schools now for medical laboratory technology that you could do the majority of your coursework online, and then you have to find a place to do your lab practicum. And finally, and I think this is the biggest, we need to draw awareness to the profession. And we also need to draw awareness to the salary range. I think part of why we can't recruit people is maybe they don't feel like financially it's a good route to go. We make less than nurses, but I think we have just as important a role to play in healthcare, but we're not patient facing. So I think people can forget about how important we are. So those are some of my ideas. I don't know, Jen, if you have something else you want to add in.
No, I mean, I think you've covered it quite well. Yeah, I think everybody is at the point where they're trying to be very creative. Adding the international workers, like you mentioned, Louise, it's really a great idea. And I think if other labs and so can explore that, I think that will probably help, although it probably will take some time. Increasing internal training programs like we have and many other places have as well. But yeah, I think it's getting that understanding to whichever level, the C-suite or administrators within the hospital systems, to recognize the importance of this specialty. And I would argue that we are patient facing in the sense that, yes, we don't, the phlebotomist, which is also part of lab medicine, we do see some patients, but we are definitely frontline, compared to nurses or pharmacists or anything else as well. And it's really just trying to get that recognized.
Yes, and with adding this, like the people that, like they have their bachelor's in microbiology and then they can do that training, I think that's a good solution as well. Because when the MLS program, you have 4 areas to choose from. And from what I've seen, sometimes, a lot of, techs, they either stay away from blood bank and micro because of the amount of technical knowledge that they need to have, Plus, about micro, they always say the ones that don't like micro, it's like, I can't stand the smell in the room, things like that. So it's hard, even
smell. There's no smell.
No. So out of those 30 that come out, maybe you get 2 at the most or 3, and then most of them end up being going to the core lab or hematology and chemistry. And you were mentioning the pay, it's something that definitely needs to be worked on. It is unfortunate, but it almost, the way that the system works, it kind of promotes techs to go from hospital to hospital in order to achieve a better pay rate. You can have a tech that starts in a company, and then after 5 or 10 years, the salary increase might be minimum. However, you might have a tech that has worked for 10 years, but maybe jump 2 to 3 hospitals at a way higher rate. And I think, unfortunately, it shouldn't be like that, because you want employee retention, right? You want to have, it's an investment, like you said. So we don't want to lose that investment. If you spend all this time training someone, you want them, they're working and happy. So it's something that it needs to be addressed. Is there anything else that either of you want to add?
Well, I would just say if you have friends or family that are coming out of college with a bachelor's degree in science, and they maybe don't have a clear career path, suggest this to them, that if they can do what's called the 4+1, 4 years for your bachelor's degree and 1 year of training, you can become a medical laboratory scientist. And I'll point you to the ASCP Board of Certification. So if you go to ASCBOC online, there's a good document that shows you, and I can give it for the show notes, of how you get these certifications and what are all the pathways.
That will be great. Yes. All right. Dr. Dien Bard, do you have anything else?
Nothing further to add other than, this is a really important topic, and thank you for inviting us to touch on it and discuss it further. I don't think this problem is going to go away. It's, if anything, it's just going to get worse. So we really do want to, or need to, put some effort and focus on this if we want to have future medical laboratory scientists working in microbiology.
Definitely, it was definitely a pleasure having both of you here. And I said this before, and I'm always a big fan of anyone that uses their training and their positions, to make this field better. It's such an important work, and it seems that both of you are trying to do that same thing, just putting the issues out there, and let's see what we can do to make it better, because we need this. It's just at the end, the ones, if we're short staffed, we get tired, we get overworked. But at the same time, one of the worst outcomes is that the patient suffers because they might not get those quality results. So it's just, and then we don't want that. I mean, that's why we do this work, to make sure that our patients get the best results out there.
Yeah. The bottom line is the patient, and that's why we should all care about this. So, and we thank you for bringing attention to it through your podcast. So it's been a joy. Thank you.
Definitely my pleasure. So once again, thanks for coming to Let's Talk Micro. And in the future, if you have any more, issues like this, or if you wish to come back to talk about another issue, please, feel free. You have an open invitation.
Awesome. Thank you.
Thank you.
And that, my dear audience, is the end of this episode. I hope you enjoy listening to this interview. As always, I enjoy sharing this information with you. Continue bringing that passion to what you do. It's so important. We do such great work. And if you're in the laboratory and you find yourself understaffed, overworked, just hang in there. It's been a tough couple of years. Hang in there. Continue bringing that passion to what you do. There's a lot of people out there trying to make things better. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.